taking a complete, reliable, and crucially, an efficient medical history.
Mm.
And we're not just talking about a list of facts here. It's about forming a watertight, coherent narrative, under a pretty significant time pressure.
It is the bedrock of diagnosis. I mean, when you really look at the research and the clinical transcripts detailing this systematic approach, you realize history-taking it's less about rote memorization and more about strategic data extraction.
Right.
But, and this is the vital nuance here, the right systematic approach is never rigid. It can't be.
It has to adapt.
It must be dynamically adjusted to meet the specific scenario, whether you're in a bustling emergency department, a dedicated outpatient clinic, or, just on a ward round.
That distinction structure as a guide, not a script, that feels like what defines an expert clinician, right?
It is.
So our mission today is to map out this entire process from, I guess, the first step of shaking a hand all the way through to building a management plan.
Yeah.
And we're starting, quite literally, before the interview formally begins, by establishing these non-negotiable initial steps.
Exactly. We call this the pre-interview groundwork, and it's just critical for safety and trust. The second you enter that room, documentation and confirmation have to be the priority.
So checking the wristband, asking their name.
You need to confirm the patient's identity and details accurately, often checking multiple identifiers, Then, for the clinical record, you document the date and the precise time of the encounter.
And beyond just the record, there's the human element. You have to establish immediate transparency.
Oh, absolutely. The interviewer needs to communicate their own identity clearly. Their name, their designation. Are you a medical student, a nurse practitioner, a consultant?
And what team you're with.
And what service or team you represent, This ensures the patient knows precisely who is asking them these, very personal questions. And, most importantly, confirms that they are comfortable and happy to proceed.
Because if they're not
comfortable, the entire delicate process of information sharing can just break down before it even starts.
So we're setting the professional and ethical boundaries right out of the gate. Okay, so once those initial groundwork steps are done, where do we shift focus? Right, we grab the essential steps.
We capture the essential context through demographics. The main three components are age, sex, and occupation.
Simple enough.
And the source material gives us a really strong illustrative example right off the bat. A 50-year-old male builder.
And even that minimal biographical sketch gives you an immediate, powerful, contextual lens. I mean, a 50-year-old male builder presenting with low back pain.
Very different set of possibilities.
A very different set of biomechanical and occupational hazards than, say, a 50-year-old sedentary office worker with the exact same complaint. It immediately starts to frame the possibility space for the presenting complaint.
Context is everything. It primes the clinician. And this leads us straight into the core of the entire interaction, what we call the history of presenting complaint, or HPC.
Right.
This is where the narrative is truly built.
The HPC is the bulk of the work. And the strategic starting point here is this funneling technique, right? Moving from broad open answers to these narrow focus questions. It starts with that initial open question. The classic is, what would you like to discuss today?
In general practice, that is an excellent starting point because it lets the patient prioritize their agenda. It puts them in the driver's seat.
But it has limits.
However, the research does note its limitations. In, say, an arranged follow-up consultation, where everyone already knows the agenda, you're there to review blood pressure, that question becomes inefficient.
You'd just ask about the blood pressure.
You'd ask a more directed question like, how has that new medication regime been affecting your blood pressure control?
Okay, but assuming we're dealing with a new, undifferentiated complaint, once that door is opened, the key is what comes next.
Strategic silence.
The importance of uninterrupted listening.
This is often the hardest skill to master. The patient should be allowed to speak without interruption, often for several minutes, depending on the time constraints.
Several minutes.
The goal here is twofold. First, you gather the maximum unfiltered information. And second, and more subtly, you build rapport and allow the patient to feel truly heard. The sheer quantity of diagnostic data volunteered in the first 60 seconds of uninterrupted speech is staggering.
I can imagine that must feel like the longest 2 minutes of your entire shift when you're under pressure in a busy emergency clinic. There's this internal pressure to just jump in when they start meandering
We
or...
haven't used the precise clinical language you're waiting for.
Yeah.
And that internal urge to interrupt is a bias we all have to fight. Once the patient has offered their open narrative, which, as you said, always leaves gaps, that's when we transition to focused inquiry and structure.
So we move from being a passive listener
To an active detective. And the challenge becomes, how do you strategically and efficiently fill those gaps?
This is where we stop relying purely on intuition and
Oh.
start relying on a verified, tested system.
Precisely. This is the utility of structure. Using a codified system is vital because it acts as an external checklist, making you significantly less likely to forget to ask about critical, sometimes life-saving features.
Like the Socrates mnemonic for pain.
Exactly. Socrates for pain. Site, onset, character, radiation, associated factors, timing, exacerbating relieving factors, and severity.
The point isn't that you must use that one specifically, but that you must always have a structure.
You must have a structure. The general principle remains. You are trying to form a coherent chronological story as to why this specific patient has presented at this specific moment in time.
And that structure acts as a guide to prompt questions, not as some kind of rigid script.
Exactly. And the source material introduces a very effective, broad application mnemonic for building this core complaint narrative. DOPS.
The DOPS mnemonic. Okay, let's really drill down into these components because this is where the clarity of the source material gets a little complex regarding that final letter.
Right. So D stands for duration. How long has the problem been present? O stands for onset. How did it start?
Okay.
P is progression. Is it getting better or worse? Now, the final letter, S, is listed as severity.
Right.
However, the source material explicitly notes that this initial S also serves as a necessary gateway to associated symptoms.
Okay, so that's a critical ambiguity for the listener. It's DOPS, 4 letters, but it really represents 5 core investigative elements.
It does.
If the structure is meant to prevent error, doesn't merging severity and symptoms risk overlooking one or the other, especially in a time-crunched environment?
That is the challenge of mnemonics, isn't it? They have to be short enough to be memorable, but comprehensive enough to be clinically safe.
So what was the justification?
The justification for merging them is thematic. Severity is often measured by the impact of the associated symptoms. For instance, if the severity of a cough is measured by the associated symptom of hemoptysis coughing up blood, they are inherently linked.
I see.
However, for a systematic approach, clinicians often mentally use DOPSS for clarity. Duration, onset, progression, severity, and then a separate, big associated symptoms.
Got it. So we'll keep DOPS in our core structure, but maintain that focus on the second S associated symptoms as its crucial companion. Let's start with duration and context. We determine how long the problem has been present for our 50-year-old male builder, let's say 3 days of dizziness.
Okay.
But the most insightful question here isn't the duration itself, it's why have they presented now?
That why now question is often the golden key to diagnosis, regardless of whether the condition is acute or chronic. I mean, if a patient has had knee pain for 5 years, we need to know what, if anything, has changed in the last 24 to 48 hours to cause them to seek help now.
It identifies the delta, the acute change in their baseline.
Precisely. Asking this question can do one of two things. It either confirms the continuation of a chronic problem that has simply reached a tipping point of tolerance, or, critically, it helps identify a new acute problem that's been superimposed on that long-standing chronic condition.
You're looking for the destabilizing factor.
You are always looking for the acute destabilizing factor.
So in the example case, the builder,
Yeah.
he usually has very steady feet, which is essential for his work at height.
Right.
He's presented because his dizziness has caused him to nearly fall over on the job site. The near fall is that acute change that necessitated the visit.
Exactly. Even if mild dizziness was present previously, that move from a benign symptom to a high-risk event is the signal. That change in functional status, as you highlight, transforms the conversation from passive cataloging to urgent risk assessment.
And that immediate risk assessment is the clinical payoff of the why now question,
Absolutely.
which moves us smoothly into section 2, onset, progression, and the absolutely critical patient perspective, the ICE framework. Let's start with onset and triggers.
The onset requires precision. Was the symptom sudden or was it gradual? Did it start in the morning or after exertion? And then the search for triggers is vital.
What are we looking for there?
We're looking for immediate associations like starting a new blood pressure pill, suffering a recent infection, or even a stressful life event that just happened to coincide with the symptom onset.
That connection between a recent medication change and a new symptom that's an easily missed but massively important piece of data. The history becomes a timeline where we correlate events.
Right. In the case of our builder, he denies any specific environmental or infectious trigger he can recall in the last few days.
Okay.
He does, however, mention that he has existing knee pain for several months and he has been taking something for it. We note that, even if it seems irrelevant to the dizziness at first glance.
A small piece of context, logged away. Now, recurrence and progression.
First, we clarify if this is a novel event. Has the patient had this problem before? If they have, what was the past diagnosis and what worked to resolve it?
And if it's new?
If this is the first episode, as it is in our builder's case, we then focus purely on progression. What helps or worsens the symptom? This reveals the natural history and the patient's existing coping mechanisms.
Understanding progression helps map the natural history of the condition. For example, if a patient says their abdominal pain is slightly better after they eat,
That immediately points us away from certain conditions and toward others, like duodenal ulcers.
exactly. In our builder's example, the dizziness is getting progressively worse.
Specifically, he's found that it is noticeably exacerbated when he stands up quickly from sitting or lying down. He also notes, regarding his chronic issue, that his knee pain has been well managed with over-the-counter ibuprofen.
That ibuprofen use is now logged twice. It's starting to form a potential link.
Yeah.
But let's look at severity and impact, the S in DOPS. How severely does this problem register? We have to move beyond that subjective pain scale, right?
Absolutely. Clinically, we determine severity not by arbitrary numbers, but by measuring the impact on the patient's daily functioning. We focus intensely on the change from their normal, established baseline.
So for the builder,
In our case, the dizziness making the builder a risk for falling, a substantial change from his normal baseline of having steady feet, that communicates severe functional impairment.
that's the clinical gold standard. If a patient is a marathon runner and now shortness of breath prevents them from even making it up a flight of stairs, that change from baseline immediately communicates severity more effectively than anything else.
It's objective. And once we've established the objective facts and the physical impact, the best clinicians pivot immediately to the patient's psychological and emotional investment.
This is ICE.
This is why the ICE framework ideas, concerns, and expectations is indispensable. Without ICE, you have data, but you don't have understanding.
Let's dedicate some significant time here, because this is often the most underdeveloped part of a history. Starting with I for ideas.
Yeah.
What does the patient think is wrong?
Ideas are sometimes dismissed as irrelevant, but they can hold critical clues, especially if the patient is educated about a family illness. More often, it's a non-medical interpretation. I think this pain is just stress, or it's probably just something I ate.
And you have to ask without judgment.
You must. By knowing their idea, you identify their current model of the illness, which you're going to have to address later.
Okay, C for concerns. This is about their worst fears. What are they worried this symptom represents?
This is where you uncover the anxiety that's driving the visit. A persistent headache might just represent a migraine to the clinician, but to the patient, their overriding concern is, does this mean I have a brain tumor?
And if you don't address that,
If you confirm it's a migraine but fail to acknowledge and dismiss the concern about the tumor, the patient will leave dissatisfied, still worried, and potentially non-compliant with your treatment plan. Concerns guide your patient education strategy.
and finally, E for expectations. This is often the biggest source of patient-clinician friction. What are they hoping you'll be able to do for them?
Expectations are about the desired outcome. Are they hoping for a specific test, a referral to a specialist, a definitive medication, or just a certificate for time off work? If the patient expects an antibiotic for what is clearly a viral illness and you give them reassurance and rest instructions instead, you fail to align their expectation with the reality of their treatment. You either meet the expectation or negotiate a mutually acceptable alternative.
So by using ICE, we ensure we are treating the person within their context, not just the isolated symptom.
Exactly.
We've established the chief complaint and the person's relationship to it. Now, we use that associated symptoms part of DOPS as the gateway to Section 3, broadening the information net through the comprehensive review of systems, or ROS.
That's the smooth transition. The ROS is the clinician's safety net. It's useful because asking structured questions across seemingly unrelated systems, cardiovascular, respiratory, gastrointestinal, might reveal features that are highly relevant to the diagnosis, but just didn't seem significant enough to the patient for them to mention initially.
This is where we catch the crucial piece of evidence that the patient, because they aren't a clinician, might have dismissed as just an annoying but irrelevant detail. Give us the critical example from our builder's case.
Precisely. So we ask our builder about general systemic features, including his gastrointestinal system. Specifically, asking about a recent change in bowel habit reveals the presence of melena.
Melena. Black, tarry stools. Now, that is not just a detail. That is immediately suggesting digested blood from an upper gastrointestinal source, and it changes the entire urgency of the assessment.
That single piece of information, revealed only because the clinician followed a structured ROS, completely changes the diagnostic pathway of his 3-day history of dizziness. It connects his vague positional dizziness to something much more dangerous, blood loss.
Wow.
And while the general ROS is broad, we have to note that each specialty will have questions that are particularly relevant for ruling out their worst-case scenarios. This is called directed questioning.
Okay, let's detail some of those critical, specialty-specific screening questions. We need to screen all major systems for red flags, starting with the cardiovascular system, which is a common cause of dizziness.
General cardiovascular screening must include asking about any chest pain and specific types of shortness of breath. For example, we specifically inquire about orthopnea,
Which is shortness of breath when lying flat.
yeah, often relieved by sitting up or sleeping on pillows. This strongly suggests left-sided heart failure.
And paroxysmal nocturnal dyspnea, or PND.
Yes, PND, which wakes them up at night suddenly gasping for air. These are non-negotiable checks. We also check for peripheral signs like ankle swelling and cerebral signs of poor output, lightheadedness, syncope, fainting, or palpitations.
Those questions efficiently rule in or out cardiac involvement as a primary cause. What about other key systems?
Other systems would include reviewing the urinary tract for symptoms like dysuria, painful urination, incontinence, or frequency. And then we have the general or systemic features that are common indicators of infection, malignancy, or widespread systemic disease.
Like what?
Unexplained nausea, persistent vomiting, fever, truly unexplained weight loss over a defined period, or debilitating night sweats.
I find the power of grouped questions fascinating, tailored to the chief complaint. If a patient presents with a headache, we don't just ask about the pain quality.
No, absolutely not. We perform what's called a focused neurological screen based on their presenting complaint. If the patient has a headache, you specifically group questions about fever, neck stiffness, photophobia,
Light sensitivity.
light sensitivity, or sudden vomiting. Yeah.
And those specific grouped questions immediately point the clinician toward potentially critical high-risk diagnoses, like meningitis or a subarachnoid hemorrhage.
Exactly. The structure guides the investigation efficiently, ensuring you don't miss the diagnosis that could kill the patient.
So if we synthesize the HPC for our example builder, using all the information we've gathered through this whole systematic process, the open question, DOPS, the expanded ROS, what's the final snapshot?
The summary becomes tight.
We have a 50-year-old male builder who is presented with a 3-day history of worsening dizziness, specifically exacerbated on standing up, and a newly discovered 1-week history of melena, or black tarry stools. That is a tight, high-urgency, coherent summary. It captures all the interwoven components.
And that takes us directly into Section 4, Past Context and Medications. The history is incomplete without understanding the patient's past diseases and their current pharmacopoeia.
We must look at the past medical history, the PMH. The value of looking at old electronic records, if you can, is just immense. We want to see if previous conditions or interventions connect, even subtly, to what's happening now.
Right, like a history of atrial fibrillation would make that dizziness suddenly very concerning for a stroke.
Exactly.
It is always preferable to cross-check patient accounts with documented records, with their explicit permission, of course. The source material highlights a crucial point here. Patient knowledge varies wildly.
I'm sure.
One patient might have an exhaustive, accurate list of every hospitalization, while another might forget major life-altering diagnoses. Checking the record verifies the story and ensures completeness.
So what does our builder's static PMH show?
In our example, the only listed past medical histories are knee osteoarthritis, which is why he takes medication, and a remote appendectomy.
And that background of knee pain?
It leads us immediately to the crucial dynamic topic of medications and doses.
We need a complete list of current prescription and over-the-counter medications, the doses, and any recent changes. But crucially, we have to assess compliance. Are they actually taking the meds as prescribed?
Or have they stopped taking something because they felt better, leading to a rebound effect? Compliance is often the hidden variable that explains treatment failure or unusual presentations. But the most important aspect of listing medications is understanding the medication predispositions and relevance, how the drug itself influences the likelihood of the current illness.
This is where we move from just data collection to predictive clinical reasoning. Certain medications are high-risk indicators.
Let's run through a few examples beyond our builder. If a patient is on strong anticoagulants like warfarin or a DOAC, they are inherently more prone to bleeding.
Right.
So any presentation involving blood loss, from a nosebleed to the melena we found, has to be investigated first with the knowledge that the anticoagulant is a likely contributing factor.
Or consider long-term high-dose steroid use for chronic conditions like rheumatoid arthritis.
If that patient presents with an acute illness, say a severe infection or trauma, they may be on the verge of adrenal crisis. Their steroid dose might need to be temporarily doubled, what we call stress dosing, to support their body's overwhelmed system. Missing that medication history is a potentially fatal oversight.
And the rise of immunomodulators.
Patients on immunosuppressive drugs for transplants, cancer, autoimmune disease, they have a fundamentally altered baseline. They are far more predisposed to severe infections, and their fever threshold for aggressive investigation is much lower.
So a mild fever that you might just watch in a normal person?
It's often an emergency in an immunosuppressed patient.
And bringing it back to our specific case, the ibuprofen use, we noted he was taking a non-steroidal anti-inflammatory drug, or NSAI, for his chronic knee pain.
And NSAIDs are notorious for causing gastric ulcers. They disrupt the protective mucosal layer of the stomach, leading directly to upper GI bleeding.
So the systematic history taking has now powerfully linked his chronic knee pain
The osteoarthritis.
with his treatment, the ibuprofen.
To his acute, life-threatening problem, the GI bleed evidenced by the melena and dizziness.
The power of connecting those disparate facts is incredible. The final part of this section is allergies. This is a critical safety check.
We must explore the presence of any drug or other allergies, and crucially, it's not enough to just say, I'm allergic to penicillin.
You need to know what happens.
You need to know what specific reaction they get. Is it a non-threatening mild rash, or is it life-threatening anaphylaxis? Knowing the mechanism of the reaction is vital for determining the safety profile of all subsequent treatment.
Okay, moving on to Section 5. Social context and physical assessment. The patient's life outside the examination room matters immensely. It often reveals behavioral causes or resource limitations.
The social history, or SH, is more than just occupation. We need details on their general level of functioning. Are they generally mobile and independent, or do they rely on carers? If so, who are the carers, and are they coping?
And who they live with.
Who they live with is important, particularly if they are elderly or have cognitive impairment, as this really impacts discharge planning.
But the core components that affect health risks remain central. Smoking, alcohol, and illicit substance use. And the measurement here has to be standardized.
Smoking history specifically should be recorded in pack years.
Right. Can you explain that?
It's the calculation of the number of packs smoked per day multiplied by the number of years they have smoked. And this isn't just arbitrary math. This objective metric gives us a quantifiable risk factor for major diseases like lung cancer, COPD, and cardiovascular disease.
So a 40-pack year history is a massive red flag.
A huge red flag, regardless of their current smoking status.
So if you smoke 2 packs a day for 20 years, that's a 40-pack year history. That standardized measurement allows clinicians globally to compare risk profiles accurately.
Right. We also need to assess alcohol use in standardized units and illicit substance use, including type and frequency. And depending on the nature of the complaint, say unexplained weight loss or potential infectious exposure, a targeted travel history and sexual history may also be highly relevant.
But that requires a lot of tact.
It requires the clinician to use that established rapport from the ICE framework to ensure the patient feels safe enough to be honest. It's an act of trust.
Okay, next up, family history. FH. Its relevance really changes depending on the patient's age and presenting complaint, doesn't it?
It's particularly high yield in younger patients, helping to identify genetic conditions. The classic example is the presence of cardiac events in first-degree family members, mother, father, siblings under the age of 50.
Why that age?
That specific early onset strongly suggests a genetic involvement, like a familial hypercholesterolemia or a cardiomyopathy, which would instantly elevate the urgency of an investigation for chest pain in a younger patient.
And you need specifics.
You have to identify the exact relations and the precise age they develop the condition. A vague heart disease is useless. Specific data points are gold.
Finally, we move to the objective data, the physical examination and investigations. The documentation of the physical exam, including vital signs, is the objective verification of the subjective history.
And the source material stresses the need for specific measures tailored to the presenting complaint, which is what differentiates an expert from a novice. In our dizziness example, a standard radial blood pressure reading is just insufficient.
You need lying and standing blood pressure, the tilt test.
Precisely. Orthostatic or postural hypotension, a common cause of dizziness when standing up, can only be confirmed by comparing the supine and standing blood pressure readings. A significant drop upon standing confirms the diagnosis and explains the builder's near falls.
And for someone presenting with, say, high-risk chest and back pain, what's another example of a specific targeted physical measure?
Taking blood pressure in both arms. A significant discrepancy, a difference of more than 20 mmHg between the left and right arm, can be a physical sign pointing towards an aortic dissection, a life-threatening vascular emergency. These targeted measures are essential.
We also have to note any recent investigations available to us, right? Blood results, ECGs, imaging reports.
Acknowledging that in general practice or emergency medicine, those investigations may not be available yet. The history and physical are still the starting points. But if they are present, they are integrated immediately to complete the overall data set before moving to the diagnostic phase.
We have now systematically gathered every piece of relevant interwoven information. So now we move to Section 6, Synthesis, Differential Diagnosis, and Management. This is where the systematic approach really pays off.
The goal now is triangulation. We have to form a problems list and a differential diagnosis, or DDX, based on the combined evidence from the history, the physical exam, and any initial investigations.
We have to write it down.
Listing the differential explicitly is key, as it provides a clear, documented framework for building a solid management plan.
So let's break down the full detailed case synthesis for our 50-year-old builder using all the facts. Dizziness, near falls, worsening on standing, 1-week history of melena, and regular ibuprofen use. We need to construct a narrative that links all these elements.
Okay, so we start with the symptoms and trace back the potential causes. Fact 1, dizziness worsening on standing. The most likely mechanism is orthostatic or postural hypotension.
Okay, so why is he hypotensive? That leads us to the second diagnosis, which is the underlying physiological cause.
Hypovolemia. Low blood volume. His body just cannot maintain adequate pressure when gravity pulls the blood down upon standing.
And what's causing the hypovolemia? This leads to the third and the unifying diagnosis.
Upper gastrointestinal bleeding. The melena is the evidence of the blood loss, and the hypovolemia is the cause of his orthostatic symptoms.
And we now know the probable origin of that bleed. The GI bleeding is strongly suspected to be secondary to a peptic ulcer, which is itself directly linked to his chronic NSAID use, the ibuprofen.
And the systematic structure didn't just identify a set of symptoms, it revealed the entire pathogenesis connecting his chronic pain to his acute instability.
Incredible.
This is also the point where we include relevant risk stratification tools. For an upper GI bleed, we immediately use scoring systems like the Glasgow-Blatchford score. These tools use history and objective data like blood pressure, urea levels, hemoglobin to predict the likelihood of needing intervention and the risk of mortality.
Why are scoring systems so important here?
They remove guesswork. The score provides an objective, evidence-based measure of urgency, ensuring that high-risk patients like our builder are immediately prioritized for resource-intensive interventions like endoscopy and transfusion.
With the differential firmly established and risk stratified, we then construct the management plan. And the plan has to logically match the issues we identified,
addressing the mechanism, the cause, and the prevention of recurrence. So let's detail the necessary steps for this builder, focusing on the immediate priorities.
Okay, first, immediate stabilization to address the life-threatening hypovolemia.
This would involve rapid administration of crystalloid fluids and a cross-match for a blood transfusion, likely 2 units of packed red blood cells, given his symptoms. Second, addressing the source. An urgent, definitive endoscopy to locate and treat the bleeding ulcer.
Third, continuous patient safety monitoring.
Keep him on a cardiac monitor and strictly measure urine output, as acute blood loss can lead to cardiac compromise and acute kidney injury. Fourth, prevention of ongoing injury. Stop all ibuprofen use immediately.
And document it clearly.
And document that risk clearly in the chart. Fifth, medical intervention to reduce stomach acidity and promote healing.
The PPIs.
Administer high-dose intravenous proton pump inhibitors, yeah. These suppress stomach acid production, which helps stabilize the clot at the ulcer site, especially important post-endoscopy. And sixth, expert consultation, an urgent gastroenterology review.
By addressing each problem, the hypovolemia, the source of bleed, risk of rebleed, cause of injury, and specialist oversight, the management plan becomes organized, logical, and maximally effective. We didn't just treat the dizziness, we treated the underlying ulcer, which required all those systematic steps to uncover.
This structured journey confirms that history-taking is inherently a fluid process, but its success relies entirely on the internal framework that's applied by the practitioner.
The structure is the compass that guides the fluidity, making sure you never miss a step or a vital piece of context. The overall goal remains consistent. Establish the reason for presentation, formulate a comprehensive differential diagnosis, and provide the basis for a reasonable, systematic, and safe management plan.
Yeah.
It's just remarkable to see how much truly vital, interwoven information is gathered and synthesized, from a complaint of simple dizziness to a plan for blood transfusion and urgent endoscopy, all driven by the relentless application of structure.
You know, the biggest takeaway here isn't the memory aid itself, but the way the systematic structure, DOPS, ROS, ICE, forces the clinician to look beyond the surface. It forced us to ask about the bowel habit, which revealed the melena,
Right.
which then allowed us to connect the chronic knee pain medication to the acute, life-threatening dizziness. The ultimate goal isn't just completing the checklist, it's about shifting from data collection to predictive diagnosis, seeing the potential diagnosis unfold before the patient has even finished speaking, and the systematic structure is the only way to ensure that prediction is safe and verifiable.
A profound insight into the strategic heart of clinical practice. Thank you for sharing your sources with us for this deep dive, and we invite you to continue exploring complex topics with us next time.